Hello, I'm Dr. Omar Bey, and welcome to the Physicians Health Network. We are, hold on, all right. We are a group of Black physicians here for two specific reasons, well, for many reasons, but two specific reasons: to improve the health of people that are of African descent, number one, and number two, to encourage Black males to go into medicine. It's so important that we support our culture as far as medicine is concerned, and that's important as far as the future generations. Our webinar is every second Saturday at 1 o'clock. You can tune in, you can go to OBHealthy and hit the bridge that is Physicians Network and come into the webinar, and you can type in your medical question. We physicians will be glad to answer all of your questions. One of the physicians, please, we have a background noise. If we could quiet background noise. Prior webinars are on our YouTube channel. That's OBHealthy's YouTube channel. Please subscribe so we can continue to bring these webinars to you. Remember, type in your question. It doesn't matter if it's a difficult question or a very easy question. Type it in, because I'm sure other people would love to hear that answer as well. I'd like to thank OBHealthy for allowing us to bring this webinar to you and allowing us to use their platform. The most important thing that I can say as we begin is, do not change any aspect of your medical care until you consult your physician. Only your doctor, only your physician can best treat your medical problems. All right, so let's get started. First thing I would like to do is I would like to introduce or have each physician introduce themselves, okay? And what we're going to do is we're going to start with Dr. Atherley. Please, can you introduce yourself?
Good afternoon, everyone. My name is Trevor Atherley. I'm a board-certified cardiologist. My specialty is interventional cardiology. I practice predominantly in the Essex County area at Newark Beth Israel Medical Center. Delightful to be here.
Thank you, thank you. Dr. Lee, please introduce yourself.
Good afternoon, Dr. James Lee Jr. I'm a second-generation board-certified orthopedic surgeon. Practice is in West Orange, New Jersey.
All righty. And Dr. Remy Prosper, please introduce yourself.
I'm Prosper Remy. I'm a board-certified internal medicine and gastroenterology. I do practice at the Bronx Care, formerly called Bronx Lebanon Hospital. Dr. Patrick Anderson used to work there. That's where we met, and then he's the one who introduced me to the group. I'm so happy to meet you guys.
All righty, thank you for being with us. Dr. Prosper is our featured topic today of gastroenterology. All righty, and Dr. Fredericks, please introduce yourself.
Hey, how you doing? Good afternoon. Dwayne Fredericks, bariatric surgeon. I practice in South Orange. I primarily do now medical management for obesity.
All righty, thank you. And Dr. Jordan Garrison. Dr. Garrison, you're on mute.
Yeah. Hi, my name is Jordan Garrison. I'm a board-certified general vascular surgeon. I specialize in disease of the venous system. I have offices in Hackensack and Florham Park, New Jersey.
All righty. And then we have Dr. Kendall Sprott.
Good afternoon, everyone. I'm Kendall Sprott. I'm board-certified pediatrician. I did critical care pediatrics for 15 years and general pediatrics, and now retired.
All right, thank you. Dr. Nelson Aluya. Dr. Aluya, your mic is muted.
Yes, good afternoon, everybody. My name is Nelson Aluya, internal medicine and pediatrics trained, assistant professor of medicine at the New Jersey Medical School, also an attending at the Newark Beth Israel Medical Center. I call myself a medical advocate. It's a pleasure to be here once again amongst my esteemed brothers and colleagues. Thank you.
All righty. Before I go to the next doctor, we have some feedback. I'm not sure which doctor it's coming from, but we have a lot of background noise. Is it possible that someone can note that there is background noise?
All
I think we may have handled it there. But please note that there's background noise. If you hear noise behind you, it's coming through. Dr. Daniels, please.
Hey, how you guys doing? My name is Lawrence Daniels. I'm a neurosurgeon, adult and pediatric neurosurgeon in Central North New Jersey and New York.
All righty, excellent, excellent. Well, thank you all the physicians that have come on today to answer questions. And let's get started. You know, our special topic today is the stomach, or gastroenterology, or gastrointestinal disease. And that encompasses the stomach, it encompasses the esophagus, the liver, the large bowel, like the colon, and the small intestines as well. But Dr. Prost here, you know, what I'd like to do is I'd like to just start off with a common problem, which is we call it GERD, or esophageal reflux, or that reflux from your stomach, that acid that comes up into your esophagus, or that tube that allows you to swallow appropriately and causes you chest pain. Can you give us some more insight on that?
Okay, guys, thank you. As you probably know, and the Peptic ulcer disease is a very common entity, affecting about 1 in 1,000 person a year in the general population. And the incidence of complication associated with peptic ulcer disease is 0.7 per 1,000 population. Generally, most of the time, we're talking about duodenal ulcer and gastric ulcer. But the most common cause, or the major manifestation of peptic ulcer disease generally is a gastroesophageal reflux disease. We talk about duodenal ulcer, we talk about gastric ulcer, but gastroesophageal reflux disease is the most common cause, is the most common manifestation of peptic ulcer disease. The reason is that because in gastroesophageal reflux disease, the way we try to teach the population, they say, if somebody got gastroesophageal reflux disease, is a very, very difficult situation. As a matter of fact, all of us at one point, we got some manifestation of gastroesophageal reflux disease. Whether we got true heartburn, whether we got some burping, whether we got some fullness, all those things can mimic or can be speaking sometimes of reflux disease. The reason we put emphasis in gastroesophageal reflux disease, this condition as a gastroenterologist, right now, we're managing like as a chronic condition in a large population. Some patients will come to you, they say, hi, doctor, my heartburn, even I'm taking my medication, is still bothering me. That's why we tell is almost in a lot of time we say it's a chronic condition. And different with a gastric ulcer disease, or duodenal ulcer, which is two entities. Those two conditions, the most common cause of gastric ulcer disease or duodenal ulcer, whether H. pylori infection or use of non-steroidal for a long period of time. There's two combinations, particularly peptic ulcer disease, gastric ulcer disease, and duodenal ulcer associated with H. pylori infection. If you come from a country with a high prevalence of H. pylori infection, like third world country, the risk of developing peptic ulcer disease, particularly gastric ulcer or duodenal ulcer, is very high. If you come like from country like from Caribbean, from third world country, the incidence of H. pylori infection can go up to 75 to 85%. And US population probably 2%. And the problem with Helicobacter infection, as you go, people, they go outside, they heard, I got the infection, the doctor said I should be treated, and get panic. There is a reason to get panic because even the World Health Organization put a H. pylori infection as a precarcinogen. So whenever you see that patient come to you, if you're gonna look for some reason, whether you do testing, whether you do endoscopy, you got to find a way to eradicate. Because in H. pylori infection, about 75% of duodenal ulcer is related with H. pylori infection. For gastric ulcer, a little bit less, 70%. So we have three major conditions when you talk about peptic ulcer disease: gastroesophageal reflux disease, we got duodenal ulcer, we got gastric ulcer. The gastroesophageal reflux disease, one thing we have to tell you, because it's a chronic condition in a lot of cases. But you have to manage it the way, whether lifestyle changes or at one time take some medication to help control the symptom. One problem, if we take 100 patients who probably got gastroesophageal reflux disease, there's a concern that this patient may have some change in the lining of the food pipe. That's why in some cases we have, as a gastroenterologist, we do endoscopy to try to see, is there any changes in the esophagus? At one point, you could put the patient at risk of developing some type of cancer of the esophagus. That's one concern. Particularly if you have consistent reflux symptom, whether you have heartburn, where what you call water brush, whether you have a typical cough, where you have regurgitation, and you got that for over a period of time, and you over 40, 45 years, is wise to look at the gastroenterologist to make sure they get an upper GI endoscopy to see whether you're not at risk of develop what we call Barrett's esophagus. That's a condition where the normal lining of the esophagus is being replaced as a result of a long-term reflux going to the esophagus. Okay. In that condition, when you have a Barrett's, what we call esophagus, that will put the patient at risk. The risk is very minimal. Not everybody who got Barrett's esophagus, what you call the metaplasia. Metaplasia is one cell, so a good cell is supposed to be on the wrong place. Mm-hmm. If you have that wrong cells, we call Barrett's esophagus, at one point that puts you at risk to develop what we call is adenocarcinoma. But this is very, very rare, and you shouldn't be panic about that. But nevertheless, is there from time to time. You're going to see some patient, he said, got gastroesophageal reflux disease for a period of years, and suddenly coming with some weight loss, problem swallowing, and develop what we call a adenocarcinoma of the esophagus. Right. But usually, most of the time, you got gastroesophageal reflux disease, you go on, you manage. There's a two component, and when you come to reflux esophagus, the component of when you got a lot of symptoms, you manage the symptom. We tend to tell the patient, particularly those who keep coming back to the clinic, they tell you, oh, I keep taking my medication, I'm not eating late, I control my weight, I still having the symptom. But you have to tell them, at one point we tell them, you got a gastroesophageal reflux disease. In your case, because it's a particular patient, you say, you have a chronic condition. Yeah. We don't treat, we control high blood pressure, we control diabetes. At one point, we say, we try to control your gastroesophageal reflux disease. We're not going to cure you from that. So the component of the reflux, we manage that. The symptomatic management for the gastroesophageal reflux disease, after you exclude the mucosal damage, the moment you get that, you got it clear, and you end up, you educate the patient, make sure that they continue to get anti-reflux measure, they control their weight, and take the medication to control the symptoms. And whatever make it worse, they try to avoid that. But
yeah, let me ask you a few questions. All right. Yep. You know, being a pulmonologist, I come in contact with this fairly often because I have patients that have the reflux bad enough that that acid actually during their sleeping hours drains down into their airway and actually scars their lungs. And some of the things that I tell my patients is that try to sleep at a 30-degree angle, you know, and to get things like a wedge foam for their bed. Try not to eat food 2 hours prior to going to sleep. try to stay away from acidic foods and stuff like that. I mean, these are some of the things that I say, and I know I'm not a gastroenterologist. Other docs, do you want to chime in? Is there anything that we need to, you know what I mean? I know we all have different specialties, but we all come in contact with this. And we all need to,
Omar,
understand it to a point. Yes, go ahead, Ken.
I think you might be part of the feedback issue. That's the first thing. But just to maybe give some definitions of some of the things that were spoken about.
Right.
When you talk about gastroesophageal reflux, anything that relates to gastric means the stomach.
Right.
And as everyone knows, the stomach is part of how you first digest food, because the stomach makes acid. And that acid sort of breaks down the food. Now, there's a junction between the esophagus, which is the tube that leads from the throat to the stomach, that prevents the contents of the stomach from coming back up. It's sort of a ring of muscular tissue. But if that ring of muscular tissue is relaxed for whatever reason, sometimes it could be distension of the stomach, acid that shouldn't be in the esophagus goes back up into the esophagus and can damage, because that tissue that lines the esophagus isn't supposed to be exposed to acid. But when it does, it can cause pain, which is the heartburn that we talk about. And it can actually, if it reflux high enough to the throat, you might actually feel as if you have a sour taste in your mouth because of what's reflux. And if that acid gets into your lungs or gets into your windpipe, can cause that kind of damage that you talk about. The other thing that he said was the duodenal or the duodenum, those kind of ulcers. The duodenum is the first part of the intestine that leads from the stomach. And so naturally that first part of the duodenum is exposed to acid, but there is a way to balance that acid. The pancreas, which also releases things to help with digestion, also makes bicarbonate, which is a base. And so once that bicarbonate hits the duodenum, it mixes with the acid in the stomach, and then it sort of gets balanced out. And so the rest of the intestine usually doesn't have an acidic piece of it to cause damage. But that's kind of what we were talking about, or some of the things that he talked about that might not have been clear about gastroesophageal reflux or duodenal ulcers. And he talked about H. pylori, which is a bacteria, which somehow or another, that the acid, in addition to destroying or helping to break down the food that we eat, also kills a lot of bacteria that we might swallow. Remember, we have a lot of bacteria in our mouth, and a lot of bacteria might hit, but when it hits that acid, they get destroyed, which is sort of helpful over time. But this particular bacteria doesn't get destroyed by the acid, and can live in the stomach and allow for that acid to damage the lining of the stomach and cause an ulceration, which can be painful. And so some of the treatments that they talked about is to maybe take an antacid or a base that might help neutralize it, a medicine that decreases the amount of acid that the stomach produces. And all of those things are some of the things that are related to that. So.
Right. I think Dr. Garrison, did you have a question, or did you have a statement?
Yeah, I have a little bit of a question and a statement. As a surgeon who deals with a lot of the esophageal reflux disorders, I noticed a reluctance of gastroenterologists to refer patients with gastroesophageal reflux disease. It seems like the indication to refer to a surgeon is when they have serious dysplasia. And my question is, why not, if a patient is on chronic medication and still continues to have symptoms on the medication and their treatment has not abated, why not refer earlier for a surgical cure as opposed to continue the medical cure? That's my question.
There about 5 to 7% of these patients who still qualify to get what we call surgical treatment for long-standing gastroesophageal reflux disease. You want to do that as early as you can, but the problem, some of those patients, there's a study come out a few years ago. Patient got surgery got some type of Nissen procedure, some type of anti-reflux surgery, because they because of intolerance to medication, whether the omeprazole, whether they cannot control, they have a lot of side effect, or they're tired of it, or maybe the occupation, you choose to send them for surgery. But the one thing I know surgeons, they're very jealous about that. We find out about 60% of patients even got some type of anti-reflux. For one reason, they have anti-reflux surgery, and they still require use of acid reduction medication, even they have surgery. And some of those patients, after 7 years, the surgical treatment is not as effective. It's a good alternative to have, but it's good to educate the patient about the downside of the surgery, because some of them, they think you got surgery, the problem is going to resolve for a long period of time. But again, we know we still refer those patients, and we're going to refer them early, because when they already got damaged, they have changes in the food pipe, they have some problem with motility of the esophagus, they're probably too long gone to make sure to help when it comes to surgery. But I agree with you, we should refer more patients, particularly if there's somebody we know they're not compliant, and they have so many side effects, with a lot of patients who's taking proton pump inhibitor like omeprazole, pantoprazole. Those patients, the same medication was there to control their reflux symptom, whether heartburn, water wash, or something. One of the major side effects of the PPI is all idiosyncratic. It's often with patients is abdominal pain and something headache. So you got a patient that got a lot of symptoms. They got water wash, they have cough. Some of them even got bronchospasm, and then they cannot tolerate. Those type of patients, that's the one you go and send for surgery. And we do have, for example, there's somebody who make a living like a singing. The patient sing and he got a reflux. In addition to reflux, he got some hoarseness. Those type of patients, there's a subset of patients we still refer for surgery, but we do have to educate those patients. When you get that surgery, some cases your expectation might not be down the line, maybe 7 years or 10 years, because a lot of them, they may have the symptom back, and they may have to take medication to control even they have surgery.
Right. Yeah.
Dr. Prosper, some patients, what do they usually take for it? If I'm getting reflux a lot of times, should I take Tums? I know they took Tagamet off. Why did they take that particular medication off?
What I'm saying, whenever you have a hammer in your hand, everything looks like a nail.
Mm-hmm.
But academically, when you see a patient who got reflux disease, if the patient tell you, I take Tums, I take my Lonta, I take Tagamet, that control my symptom. Whatever control the symptom, that should be enough. You don't have to go and jump and use some PPI, with very expensive. But if the patient cannot tolerate, and you go first-line therapy, you got anti-acid, you use H2s, we're using less and less, and is on PPI. But any medication to control the symptom, you're going to do it. If the patient come to you and for some reason he said, whenever I drink that stuff, I feel fine. Academically, you could tell the patient continue what you're doing, because there's no guarantee adding a powerful proton pump inhibitor is going to make a difference. So what I'm saying.
Can I ask a question?
Yeah.
Yes.
Go ahead, Dr. Atherley.
Dr. Prospero.
Yes.
As a cardiologist, I know that there is significant overlap in the symptoms that your patients may have compared to mine. And it does cut both ways. In fact, I know that a significant minority of patients who are actually having heart attacks may assume that this pain that they experience is originating from somewhere in the stomach and hesitate. You've noted delays of up to 3 hours for the average patient before seeking help for severe heart attacks. On the other hand, I see many patients who have gastrointestinal disease in your field, who come to me assuming that the pain they're having from the stomach is of cardiac or heart origin. Or a lot of the pain is felt in the so-called epigastric region. That's the pit of the stomach. And maybe you can tell me some of the clues that you might want to impart to your patients so they will know whether they should come to see you or a gastroenterologist or whether they should more immediately seek the help of a cardiologist. What sort of things would you tell your patients to steer them either towards or away from you?
Well, that's a very good question. It's going to be a one by one basis, but whenever you have the patient who got some chest pain or atypical chest pain, we know we have 70% of the time when you see this patient, we could have an idea about what's going on, but those, unfortunately, the chest pain they tend and cardiac patient they tend to overlap. And at one point, for some reason, there's a study a few years ago calling patients who got gastroesophageal reflux disease. For some reason, they must have more symptoms who might be triggered by the esophageal symptom who trigger cardiac, so whether the patient have breathlessness or shortness of breath or exertional dyspnea. The reflux symptom might trigger those for some reason. But anytime you see somebody who got high risk, somebody who over 50, somebody who got coronary artery disease, who got hypertension, who got family story, he come to you as a gastroenterologist, the pain is a typical, and at the same time, he throw at you that I have some discomfort, he's a smoker, he got history of alcohol use, he got a family story. Those type of patients, we use the algorithm. If you have cardiac chest pain, the gastroesophageal reflux disease is not going to kill you. But if you got angina, you have a typical coronary disease, with what we call GI manifestation of non-GI diseases. So somebody got bad coronary disease, we still refer a lot of them to cardiologists to evaluate. So the right patient who got a very significant risk factor, got coronary artery disease. In addition, he got diabetes and overweight. Those type of patients, before we can do anything regarding GI intervention, whether we got some upper GI endoscopy, some motility study, cardiology, they should see a cardiac specialist, a cardiology first, before they get engaged in some type of very expensive or extensive workup, do endoscopy at one point.
I certainly agree with you, Dr. Prosper, and that's a very valuable point, maybe to emphasize, if not overemphasize. You know, the old adage about we can be judged by the company we keep also applies to chest pain. And when I see a patient with chest pain, especially one presenting for the first time, we like to first of all determine if there are significant factors, so-called risk factors, that can predispose this patient to heart disease, especially that caused by blockage of the coronary arteries. So again, we would repeat a family history of members of the family having had heart attacks at a young age, generally males under 55, or females under the age of 60. And we look for other factors which might indicate that the pain itself, when it's occurring, might be of cardiac origin. Diaphoresis or breaking out in a cold sweat, shortness of breath, palpitations, which may be a feeling of an awareness of the heart beating. You shouldn't feel your heart beating. An awareness of the heartbeat, which might indicate to us arrhythmias or irregular heartbeats. A feeling of faintness, dizziness or faintness as though one might pass out, which again might be an indication of arrhythmias or irregular heartbeats, or it might be an indication of the blood pressure falling because of the severity of the effect on the heart. So I agree that certainly the company kept by the chest pain is important. The underlying risk factors that predispose one to serious heart disease is also extremely important.
All right, thank you. Listen, I would love to stick with this topic, but we have a lot of questions coming in, and I'd like to.
Dr. Bay,
go ahead.
Dr. Bay, if you don't mind my saying something quickly.
Go ahead.
Right. As a pediatrician, as an adult doctor as well, I've seen, gastric GERD or gastroesophageal reflux beginning from babies, even in the nursery up to 100-year-old and those in the nursing home. So, but one of the things that we need to understand, other than a historic perspective, where it was first described in 1925 by, some brilliant doctor, and then actually first written out, I think in 1935 by a gastroenterologist in the medical literature. We need to understand the risk factors that constitute us having gastroesophageal reflux disease. One of them is obesity, for those who smoke, for those who take certain medications, especially NSAIDs. Those are NSAIDs like ibuprofen, naproxen, and all of this. And if you take a whole lot of it for one pain, usually from arthritis or everything else that they do, and then pregnancy itself puts you at risk. Some people have said for those who drink a whole lot of coffee, those things put you at risk. So, but then the signs and symptoms, what does it mean? As Dr. Presper and a few other of my colleagues have said something about that earlier on, that feeling of the stomach content in your throat, bitter taste in your mouth, otherwise called the water brush, foul breath, feeling of unease, But then outside of that, alarm symptoms that need you to seek help immediately if you begin to have some of this reflux. Because at one point or the other, as long as you're a human being, you would have had one symptom or another in your lifetime. We all have, as doctors, as colleagues, and we come back late, we eat late, we have that. But the alarm symptoms that make you say, you know what, this is not ordinary anymore. For instance, and I've seen this often enough. One, if you have the chest pain that you usually have, now the pains begin to go to your back. You have the same pain, but you're feeling the pain from your back. An alarm symptoms. You're losing weight. It's an alarm symptoms. Or you're vomiting profusely, or you can't eat or swallow anything. Alarm symptoms. Or it gets to a point where you begin to vomit and then you vomit blood. Those are alarm symptoms. Now, as a pediatrician, in kids, they're very difficult to pick up because children will not tell you how they feel. But in the neonates, in babies who just took their mothers home, mothers who just took their babies home, one of the things that they see is that you find the baby crying constantly, repeated crying, and then inconsolably. Or the baby is crying for food, you give the baby the bottle or the breast, and instead put it in the mouth and push it away immediately. That's one of the early signs of reflux. Or the baby is having profuse vomiting or spitting up, constant spitting up. Or the baby is having to lose weight, not gaining weight even then when they're eating. Or the baby is having respiratory problem. You lay the baby down, it can't breathe. You're having respiratory or signs and symptoms, or seems like asthma. Those are signs for every mother to take care and be aware of, to say, you know what, this is not right. This is something that needs a pediatrician's what do you call it? A review, and then the pediatrician will take a great amount of history from you and then refer you to the appropriate
Excellent. That was a great review there. Great review. Let me do this. Let me take some of the questions that are coming in. Dr. Lawrence Daniels, are you still with us? Is Dr. Daniels with us? Because I think he's going to have to help us out on this one. If not, then I'll come back to it. All righty. I'm not sure if Dr. Daniels is with us, but here's the second question. A relative wants to lose weight and keep it off. She states that she knows how to lose weight, but ultimately puts the pounds back on. She is thinking about getting the operation, which is, I'm assuming, some type of gastric operation. What is the fastest weight loss operation that is effective? And should she go that route? Dr. Fredericks, and I know Dr. Garrison was on and he'll sign on later. Go ahead, Dr. Fredericks.
That's a complex question. Weight loss, weight is very particular. And I don't do surgery on a person who's heavy. You have to be a certain weight. You have to figure out what their BMI is. That's where I take their height and their weight, and I put it in a formula. If you get too heavy, you start to have problems, can lead to heartburn, it can lead to hypertension, it can lead to diabetes. So having too much weight can become problematic. So if your BMI is greater than 35 and you have health-related issues like the hypertension, the diabetes, and things of that nature, you qualify then for weight loss surgery. Or if your weight is greater than 40, you qualify for weight loss surgery without having to have these particular comorbid conditions. Now, there are three major types of weight loss surgery. Two of them are restricted. That means they limit the amount of food you can actually take in. And that's the sleeve gastrectomy and the band. The band has sort of fallen out of favor because the band is a device you put on over the top part of the stomach and restricts the amount of food you can take in. But for the band to work effectively, it has to be properly adjusted. That means you have to come see me once a month and have to determine whether you need to get a fill to make that area tighter to restrict the amount of food you can take in. And so that can become problematic. It takes a lot of time to get that right spot where you lose an adequate amount of weight. Of all the three types of surgeries, this is the safest surgery to do. And but the fact that it's safest, it could take a little longer than the others to lose that adequate weight. The next restrictive procedure is probably the most common bariatric procedure to do, which is called the sleeve gastrectomy. And that's where I take your stomach and that's shaped like a football, and I cut it and shape it into a banana. So it restricts the amount of food you can actually take in. Now, all these procedures are actually very safe. Despite what people may tell you, bariatric surgery is probably one of the safest procedures that we're doing because the technology is now advanced to the point where you do it all laparoscopically and now even you do it robotically. And so with all that, we get good visualization. So we see exactly what we're doing. We can follow you and make sure that we're checking to make sure there's not a leak or anything like that associated with it. So from doing these procedures, we're knowing that they're very safe. Patients lose that weight and get better. The last procedure is the one that's probably the greatest amount of weight loss, which is the old standard, which is the gastric bypass. And with that procedure, I cut the top part of the stomach and form it into a little ball. And then I take the intestines and reroute it up to that little ball. So that little ball restricts the amount of food you can take in. And when it's going down that intestines, it's controlling how much calories I'm actually absorbing. So I'm absorbing less calories, taking in less calories, losing more weight. And even this procedure is very safe. So the safest procedures, the band is the safest, but we're not doing it as frequently as we do now. The next safest procedure is the sleeve gastrectomy, where you lose a lot of weight, you get all those comorbidities back to resolve, and the gastric bypass. And the gastric bypass, I kind of use that for patients that have difficult diabetes, because right on the table, when I'm doing that bypass, that insulin requirements goes down. So if you have a brittle diabetic, this is probably the best procedure to do.
Okay, excellent, excellent. There's another question that came in, and we're going to see if we can answer as many as possible. I use the medication mixilotine for heart arrhythmias. Does that mean heart failure could happen in any certain time range, like 5 years or so? Dr. Atherley, can you help us out with this? You're on mute, Dr. Atherley.
Thank you. I'll endeavor to answer that question as briefly as we can. Mixilotine is one of a class of drugs called antiarrhythmics. It is used to help control irregular heartbeats, usually the more lethal kind of irregular heartbeats, those originating from the lower chambers of the heart called the ventricles. So it is not a commonly used medication nowadays. So we do not have large current studies on it, but we do have some older studies which we can refer to see the effects of mixilotine. Now, mixilotine may have what is called a negative inotropic effect, and of course I will explain those words. It means that it may weaken the strength of the heart muscle. This is a very mild effect. It is not seen in the vast majority of patients who are placed on mixilotine. It can, however, by weakening the heart muscle in those who already have a significantly impaired strength of the heart, those whose heart muscles are already significantly impaired, such as we might consider in the so-called congestive heart failure, people with severe congestive heart failure, it is possible that it can worsen them and thus make the symptoms or the feelings that are associated with that heart failure become more profound and more obvious. However, I would dare say that in the majority of people who do not have that effect and who start off with normal strength of the heart, that it would not be expected that mixilotine would cause any significant weakening of the heart in short or even long-term foreseeable events. I will say that one should be more concerned, I suppose, about mixilotine in its use in terms of potentiating arrhythmias or irregular heartbeats, in terms of causing symptoms that relate to other systems, such as the stomach and the intestine, where one may get nausea, vomiting, etc., some upset, gastric upset, and of course, one may have dizziness. But I would urge that the individual who asked the question not be as concerned in patients who do not have severe impairment of the heart strength or function. I would not be as concerned about the use of mixilotine in potentiating or worsening the heart function.
Okay,
Can
excellent.
you talk a little bit more about what heart failure is? It's a common expression, and I'm not sure people truly understand what it means.
Okay, I sort of assumed that the questioner himself had a specific reason for asking that. Let me explain then, I must go back to the basics of what the heart does so we can explain what it fails, what the manifestations of the failure may be. The heart is the most muscular and strongest pump that we have in the body. As you know, it beats incessantly, it doesn't stop. It continues to beat for the duration of our existence. During this time, the heart, of course, requires its own blood supply and its own nutrient supply. Although its job is to pump these around to the rest of the body, the heart itself must receive these so that it can function effectively as a strong muscular pump. Now, there are several ways in which the heart may fail, but the commonest one that we have studied and that we discern and diagnose is so-called congestive heart failure, which in most instances implies that the heart has become weakened. It no longer functions as a strong and effective pump and doesn't do its job well. Now, what happens if the heart fails with so-called congestive heart failure and doesn't do its job? Well, there are two ways. There's forward and backward. In terms of not pushing blood forward properly, one may experience weakness, fatigue, difficulty in carrying out normal physical activities which you might otherwise have been able to do because there's not enough blood going to the various organ systems to do that. On the other hand, there's backward failure. That is, by not pumping the blood properly forward, it allows backward accumulation of blood and fluid. Where to? To the lungs and the lower extremities. So you may have difficulty in breathing. This may be difficulty in breathing with exertion, or in a more profound status, difficulty in breathing, even laying quietly. And this is sometimes manifest worse at night when you assume a position of laying supine, laying your back, and blood which had accumulated in some parts of the body, in, for example, the lungs or the lower extremities, returns to the heart in increased amounts and is not pumped forward properly, then that blood may raise the pressure in the veins from the left side of the heart, going back to the lungs, and this may be manifested by shortness of breath at night. You may have to prop up higher on pillows. You may get to sleep and suddenly wake up with inability to breathe properly and have to sit up. Oftentimes people talk about sitting on the side of the bed or standing to be able to improve their breathing. So in congestive heart failure, these are some of the manifestations. The one that may be seen, if not felt as much, but may be seen, is swelling of the lower extremities, because the heart may fail in its ability to pump the blood properly around the entire body. And the area in which it will accumulate because of the gravitational pull is in the lower extremities, the lowest part of our body. So one may see edema or swelling of the lower limbs. These are some of the common manifestations of congestive heart failure, and that is the commonest kind of congestive heart failure. We are also aware nowadays of a kind of congestive heart failure in which the heart is not weak. Some of you may have heard this mention of diastolic heart failure, but we don't want to dwell on that. What it implies is that the heart muscle becomes stiffened. And And so not only is there a concern about the heart not being able to squeeze blood out properly, but there's difficulty in blood filling the heart because the heart muscle is so weakened that it is with greater effort that it has to fill the heart, fill the chambers, especially on the left side of the heart. And that allows accumulation of fluid into the lungs and the lower extremities and other areas of the body, much as in the other kind of heart failure that I initially alluded to. So there are several areas or several kinds of heart failure, but that is where when one performs the normal test to look for the strength of the heart, you may find that the heart appears to be quite strong, but nonetheless, it still is malfunctioning and not filling properly and not fulfilling its job as a pump adequately.
Excellent, excellent. There's another question here.
Dr. Lawrence came back.
Excuse me?
Dr. Lawrence came back.
Yeah, I know. Thank you. And Dr. Daniels, hopefully you can help with this. I know that let's check this question out. Good afternoon, and thank you for doing this. A good friend recently died from breast cancer that metastasized to the brain. Are all brain cancers ultimately fatal? And I think that maybe several of us can chime in on this. I know that we don't have an oncologist here, but let's see if we can answer this question.
Well, I mean, I'll be able to answer the question. Are you guys hearing feedback from me?
It's pretty good. It's pretty good. It sounds,
okay.
We can understand you.
Okay, all right. So 2 things. So, and I typed the answer to the question. I'm sorry I missed it. A patient gave me a call, but I'll answer the question live. So the answer is that no, all brain tumors, I'm not going to use the word cancer because in medicine, we use very specific terms to communicate the severity of a disease. And in the public, cancer is has a certain connotation that's different. So what I'm going to talk about are brain tumors, right? And brain tumors are abnormal cells in the brain that have a tendency to grow and multiply. Another term for them are neoplasms. So brain tumors are these cells that grow and then they begin to push on the surrounding brain structures, or they can even invade the surrounding brain structures and destroy them. All brain tumors are not lethal. The majority of tumors that occur in the brain themselves are actually not lethal. But sometimes they have to be taken out even if they're not lethal in order to prevent them from continuing to grow and cause problems. But if you take them out, you can live a long and fruitful life. Now, there are some brain tumors that are extremely dangerous. And even if we take all of the brain tumor out, the tumor has the ability to appear in other parts of the brain that were not noticeable at the time of diagnosis. And they then therefore require additional therapies besides just removing the tumor, such as radiation or even chemotherapy. Now, to specifically get into metastatic brain tumors, which in adults are the most common type of brain tumor, metastatic brain tumors are tricky in the sense that you can have a breast tumor that can be treated with chemotherapy very well, that can be very responsive to medication. But if it travels to the brain, then it doesn't respond to medication very well. And part of the reason why that is the brain has a special type of barrier that protects it from other things that occur in the bloodstream. It's called the blood-brain barrier. And the blood-brain barrier doesn't allow typical chemotherapeutic agents into the brain. And so if you have a tumor in the breast that might carry a certain prognosis, that might have a certain life expectancy based upon treatments that are available, or even in the lungs or even in the liver, if it travels to the brain, the prognosis is usually significantly worse because a lot of the medication we use to treat it in the brain doesn't enter the brain.
Excellent answer there. Excellent answer.
Sorry, I have a question. I think it's for Dr. Daniels, if you don't mind, because somebody did ask me that question this past week about brain tumor and how lethal they are and if they can be treated. and because members of his family had died at a young age from brain tumor. And I was trying to tell them, one or two, a few people had asked, uh, but some of the brain lesions that occur, but a lot of them I don't know much about, but I'm sure maybe you can, tell us, especially on the glioblastoma multiforme or multiform that they talk about. If you could, highlight a little bit.
Absolutely. So tumors, so we were just talking about metastatic tumors because that was the question. We're going to talk about primary brain tumors. Tumors that occur, remember, tumors are abnormal cells that multiply and begin to occupy space and begin to damage either surrounding structures or invade surrounding structures, right? So these tumors, these that are made up of these cells that multiply and they don't stop growing like normal cells do, well, they're made up of the same cells that are in the brain. Now, if you think about it, we tell people that neurons, which are the main cell that gives way to brain function, they typically don't grow. They begin to actually reduce in numbers after puberty for everyone, for the most part. So cells that make up neurons are not typically the type of cells that lead to tumors in the brain. There are some neuromas, right? There are some cells of neural origin, but there are other cells that support the brain to do its function. Some of those cells are glial cells and astrocytes. These are supporting cells. And these typically are the cells that begin to multiply and form tumors. Now, there are so many other different types of cells. Another common cell comes from the covering of the brain called the meninges. And that type of tumor is called a meningioma. So it's not a tumor of the substance of the brain, it's a tumor of the outside of the brain, right? Each of these different cell types have certain features that these cells can pick up while they're multiplying to make them more dangerous than others. So when cells multiply, they have to copy their DNA. And while they're copying their DNA, you can make genetic mistakes that can give these cells advantages that allows them to escape the immune system and sometimes even escape therapies. These cells also can have advantages like harvesting blood supplies to them that allow them the ability to grow rapidly. So depending on which genes are turned on in these cells, some of them might be more dangerous because they have a greater ability to grow and occupy that space. So that's just a small fraction of the factors that contribute to how aggressive a tumor might be. And in order to really get a handle on how aggressive that tumor is, it oftentimes requires us to take a piece of it, send it to a pathologist. Now, 30 years ago, all we would do was look at it under a microscope, and we would look at some of the archaeographic characteristics of the tumor and decide this is a glioblastoma multiforme, which is the most dangerous type of brain tumor, or this is a grade 1 glioma, which only has some of those features that would tell you that this tumor is really dangerous. Now that we've unraveled the human genome and we're beginning to identify which genes are turned on and off, we can look at which genes are turned on, and we can say that these genes indicate that this tumor will behave like this. And these genes indicate that this tumor might be responsive to this medication. So to make it pertinent to the audience, if you are diagnosed with a brain tumor, it is not a death sentence, right? There's so much more that goes into how that tumor is going to behave. And there's a lot of work that goes into sorting out how that tumor is going to behave, how aggressive it is, and furthermore, what therapies exist to treat it. And the last thing is, the technology is so advanced and it's progressing so rapidly. The way we treat tumors today, I have a young lady, a 19-month-old that I resected a medulloblastoma on 3 days ago. The way we're going to treat her now is different than the way we were treating her 3 years ago. We would have treated her 3 years ago, right? And our ability to impact survival in these tumors is significantly better than what it was only through.
Thank
All
you.
right.
Went on pause. I just want to say a couple of things that brain tumors in children are not uncommon at all. And one of the important issues about brain tumors is that the brain is in a closed space. That means there's not room for anything other than the brain to be there, which is why if you have head trauma and there's bleeding that occurs, that bleeding increases the additional amount of space there and can compress that part of the brain that controls vital functions. And so, and if anyone has the growth of a brain tumor, then some of the symptoms that they might perceive are related to the fact that there's an increase in the amount of pressure within that space. And so that raised intracranial pressure, or the cranium, which is the covering of the skull and the brain, can cause you to have symptoms like headache or vomiting. That might be important. And even some of the primary tumors, as Dr. Daniels mentioned with the blood-brain barrier, chemotherapy historically has never ever been an important component of treating brain tumors historically. When I was being trained, some of the neurologists wouldn't even consider chemotherapy because it almost never had a play. But over time, they have developed certain kinds of drugs that can cross the blood-brain barrier. But even under those circumstances, if there is a diagnosis that's going to be made, and even leukemias, one of the things that we used to do, which with people that have leukemia, which is not a solid tumor, but a tumor that's within the blood. If the cancer cells got into across the brain, you do a spinal tap, then that meant that you have a very, very increased risk of mortality than if you didn't, which is why when you make the diagnosis of leukemia, you do a spinal tap looking for the cells, and if you haven't, then they want to give you radiation and or chemotherapy to try and deal with it. And so even though many of the tumors are not cancerous, anytime that they increase the size or the space that's there, you can develop symptoms. And if those symptoms are related to that part of the brain that controls your vital functions, it can be lethal.
Interesting. Let me go to a question for Dr. Lee, and thank you, Dr. Sprout. Dr. Lee, I had my left knee replaced and it is doing well. My right knee needs to be replaced, but the doctor won't because of my heart and lung condition. What can be done to help? Do I need clearance for ongoing surgery from a lung and a heart specialist if I'm going to really ask the physician to do this second knee?
Oh, yeah, that's a good question. I think when you have elective surgery, planned surgery, such as a knee replacement, that means it's not an emergency. And what we do is we risk stratify the patient. What does that mean? It means we say, okay, tell us about your medical conditions. And you clearly, and this individual is clearly identified that they have a lung and a heart issue. So as a surgeon, we can say, okay, this is your x-ray, this is your MRI, your physical exam is the following, and you've had injections and you've had physical therapy and you've tried medications, and you're a surgical candidate. When we look at that patient's candidacy, we have to say, are you a good or bad candidate? And that's where we defer to our medical colleagues and we say, okay, well, Dr. Bay, you're the treating lung doctor. What is this patient's chances of having a surgical issue or medical issue after surgery or during surgery? The same as with the heart, we would talk to someone like Dr. Athley and say, can you risk stratify and say, is this too much of a hit, quote unquote, the anesthesia, the blood loss, and the stress of recovering from surgery? Is it too much to the point where the risk of surgery is too high versus the benefit of the surgery itself? And in an elective situation, we're very conservative. We would certainly think it's safer to make sure that the medical conditions are adequately treated. And if they're too high risk, then we would say it's probably not a good idea to have that surgery because you might have a complication. I did allude to some alternatives, physical therapy, injections, bracing. Those are temporary ways to treat the issue. We also have talked about weight loss and general healthy living and lifestyle, and that is also a big part of it as well. So if the individual is too high risk, we generally would say it's probably not a good idea to have that surgery.
Is there any, let me ask a question. Is there ever a time that when the patient states, the pain is so bad and I've tried all of the medical treatments, I'm willing to take the risk? And how do you handle that?
So that's where we discuss the idea of shared decision making, and we say, okay, we're going to talk together about what this means. And I think shared decision comes down to fully understanding the risks of surgery, the risk of no surgery, and what that means. And I think if there is a support system involved with this individual, it's an elderly person, or if they have extended family, making sure that they talk about it in full detail, knowing that this potentially could be life-threatening, and they need to plan for end of life care essentially, or plan for if they do not survive the surgery. What is are you willing to basically make those plans? And I think there have been situations where you have people who are very high risk, and one of the hospitals that I have privileges at, Newark Beth Israel Medical Center, we have a lot of high risk patients, transplant patients, people who ejection fractions are minimal. You look at them and say, wow, how are you still living? And they say, they're giving up a decent life expectancy. Maybe they have a transplant done and say, listen, I want to have something done because these next 5 years, I just want my knee to feel better. And I think if you manage expectations and you manage risk and you get all of the doctors to work together so that we really get ahead of it, then there is a chance you could have that surgery.
I think one of the other components of that is the risk of anesthesia. And so a lot of the issues relate to whether or not an anesthesiologist will put someone to sleep if they don't think that the person's going to wake up. And the person also talked about clearance. And so if there are ways that you can reduce some of the risk of anesthesia, and if the cardiologist who knows the patient and knows what the patient's tolerance might be, will become part of that decision-making process as well. But I think that it's not just the surgeons themselves, it's the anesthesiologist that's going to want to say, because whenever you consent to surgery that's going to require anesthesia, you have to get a consent for anesthesia as well. Correct. And sometimes they will be reluctant to want to say yes, unless they get someone like Dr. Atherley to say, I think that this person might be able to tolerate both the anesthesia and the surgery.
Right. Excellent. All right. Dr. Atherley, you are mute.
I just want to be sure there's no background noise. I'm currently still in the hospital and occasionally there are announcements. Anyway, let me just answer to amplify Dr. Sprott's excellent point, that it's the anesthesiologist and not only the surgeon who may be requiring that we clear the patients from their viewpoint. And I think there's several things that we look at in terms of the potential complications of putting a patient under anesthesia and having them wake up appropriately. We tend to do what is called risk stratification in looking at some of the things that which can predispose the patient to having an adverse or an ill effect when put under. We look to see if there's congestive heart failure, and we look for the severity of the congestive heart failure, as I previously defined what congestive heart failure was for those who heard, but a weak heart, basically. We look to see if the patient has had a heart attack. We look at when the heart attack may have occurred and the degree of recovery from the heart attack, as opposed to one who's still having active angina. We look at the presence or absence of arrhythmias or irregular heartbeats, again, to see whether that may interact with the anesthetic. And we are concerned about the other non-heart problems, which also may have an ultimate effect. For example, the presence of uncontrolled high blood pressure, patients having had recent strokes. These are some of the factors that we look at in deciding whether or not the patient will have a good outcome or an adverse outcome as a consequence of these underlying or pre-occurring risk factors. So when we do that and we do a computation, we can then give a note to the anesthesiologist and the surgeon and say, based upon the kind of surgery that you are planning, this patient may be considered high, moderate, or low heart risk. And then you can decide based upon the need for surgery whether or not it is worth taking that risk, high, moderate, or low risk, to improve the patient's overall status. So yes, it sometimes becomes very important to pre-evaluate these patients.
Yeah, I do have a question. Sorry about that. Dr. Atherley, oftentimes we run into two types of patients. You know, in the hospital, you have your acute hip fracture and an 80-year-old who maybe has cardiac, you know, history of cardiac diseases on a blood thinner such as Plavix or aspirin. And in our orthopedic world, we are starting to operate through the blood thinner. We're saying, okay, you know what, if we don't get to the patient within 48 hours, our mortality rate goes up. Therefore, we're going to take the risk of operating through the blood thinner, try to control the bleeding as best we can. Can you compare that to the elective patient that is maybe on an aspirin or Plavix, say for an elective total joint replacement? And what are your thoughts on the acute patient that, you know, is more of an emergency blood thinner or no blood thinner, and then the one who is elective, where you stop the blood thinner and maybe give them a bridging dose of something, say 5 to 7 days before surgery? Do you have thoughts on those situations?
Yes, we most certainly do. I think that one has to understand the totality of the situation. And I'm quite prepared to bend or to allow a patient to have surgery, which may be considered a high risk, if the surgery is needed urgently. So I often am inclined to tell the surgeon and the anesthesiologist, yes, this patient is cleared at such and such a risk, but I will clear this patient for urgent or immediate surgery if required. On the other hand, I'd be much more lax to clear certain patients if there is the potential to take your time and appropriately prepare the patient for surgery. One example of that, of course, as you mentioned, in patients who may have the tendency to bleed, is to have a time for the anticoagulation or the bleeding medication, the blood thinning medication, to get out of the patient's system. You can give them shorter acting medications as a bridge, as you mentioned, while awaiting the time for the longer acting to get out of the system. And then you can stop those short acting and allow the patient to be subjected to surgery very shortly thereafter, knowing that there will no longer be enough of blood thinner in the body to cause them to bleed. That's one of the examples. There are other situations where it becomes quite dangerous to stop the medications. For example, when I put stents in patients' arteries, and that is a small wire mesh, which is placed to help keep the artery open after I have opened it with ballooning. We have in the past, I don't want to go into much detail in terms of that, but at times it becomes necessary to open blocked arteries in the heart and to put that little device in called a stent to keep the arteries open. Well, it is mandatory that for a short period of time at least, and we're looking at shorter and shorter times, but it becomes mandatory to continue such patients on some kinds of weak blood thinners called antiplatelet agents. These help some components of the blood to not cause immediate blockage, which is a possible complication if you stop these medications. So if patients are on these medications, I am very much more reluctant to stop them in the setting of an acute or very recent heart attack or a very recent stent being placed in the arteries. So one would have to be very seriously concerned about the need for surgery to allow such patients to have them acutely.
Excellent, excellent. Yeah. All right. Yeah. You know, the thing of it is that I know that heart is an issue as far as clearance is concerned, but the lung as well. And I know I get a lot of requests to clear patients either in the hospital or from the office for elective procedures. Now, the thing of it is that with the lung, what we usually need is what we call a pulmonary function test or a lung function test that will allow me to understand how open the airways are, how efficiently the lungs are able to stretch to take the volume in. For our height, weight, size, sex, and age, we should all be able to take a certain volume in. And then to also understand, once the air is in the lungs, how easily does the oxygen component of that air diffuse or move across the fine membrane of the lung and from the lung into the bloodstream. And evaluating that, as well as evaluating your chest X-ray to make sure that there is, for instance, there is no congestive heart failure or no scarring of the lung or no reason on the chest X-ray that would inhibit oxygen being delivered to the body. Then from there, we can determine whether it's safe from a pulmonary or from a lung standpoint, whether surgery should go on. I mean, you know what I mean? We should clear the person for surgery. But those are some of the things that I look for when I'm clearing a patient that needs surgery, either a surgery that's necessary acutely or the elective surgery you have to evaluate appropriately. Any other thoughts on this?
I just wanted to raise one other thing, and that I use my brother Trevor for consultations. And as you get older, you have relatives that have issues. And I just wanted to, I had an uncle who passed, but one of the things that comes into play sometimes with the hearts are some of the valves, and if there are valvular issues that are there. Another aspect is that if you have individuals that have had symptoms that related to narrowing of the arteries that go to the brain, that also may indicate that you might have narrowing of arteries that go to the heart. And what happened in this particular case was he had a procedure related to a valve, and then had suffered a heart attack because there really hadn't been adequate evaluation of how necessary it was. And they then ended up putting stents in him after he had the heart attack. But I think that it is important that if there are concerns about the heart, for the cardiologist to be involved and to make sure that some of the risks that might happen during anesthesia for someone that has a borderline compromise of coronary arteries, that's taken care of before the fact as opposed to after the fact.
Excellent, excellent. All righty, that was excellent as far as that question is concerned. I enjoyed that. Let's take our halftime break here. What I'd like to do is I'd like to let each of us reintroduce ourselves. And I must apologize at the beginning because I let everyone introduce themselves, but I forgot to introduce myself as usual. Dr. Prosper, could you, I want to try to unmute you, but could you introduce yourself and let's start the second half.
Okay, my name is Prosper. I'm a gastroenterologist practicing in the Bronx, Bronx Care, and I'm also in private practice. I used to work with Dr. Anderson a few years ago when he used to work in the Bronx.
Oh, excellent, excellent. Dr. Fredericks, please.
Dwayne Fredericks, bariatric surgeon. I primarily do now medical management for obesity. My office is in South Orange, Omega Weight Loss Center.
All righty. Dr. Atherley.
My name is Trevor Atherley. I'm an interventional cardiologist. I work predominantly out of Newark Beth Israel Medical Center. Thank you.
All righty. Dr. Lee.
So James Lee Jr., board certified orthopedic surgeon. West Orange, New Jersey is my main office, and Greater New York area as well.
All righty. And Dr. Sprott.
Kenny Sprott, board certified pediatrician. I did 15 years of pediatric critical care and longer years of general pediatrics.
Excellent. Dr. Aluya.
Well, Nelson Aluya, medicine pediatrics trained, medical advocate. I'm glad to be here. Thank you.
All righty. And Dr. Daniels.
Hey, again, Lawrence Daniels, adult and pediatric neurosurgery. It's a pleasure to be here amongst these gentlemen here today. And yeah, that's it.
All right, thank you. And I'm Dr. Omar Bey, pulmonary critical care. It was a subspecialty in nutrition, and I'm just overwhelmed with all of the knowledge that's being bestowed today, and always just enjoying all the brothers here with the Physicians Health Network. Let me just go over some basics. Understand that every second Saturday at 1 o'clock, all you have to do is go to OBHealthy, and basically you will be able to hit a Physicians Network and come into the bridge and open up, and our webinar will be on your computer. Ask your medical question. All you have to do is type it in. Remember, if you miss our webinars, they're on YouTube, and please subscribe. You can see all of our past YouTube webinars under OBHealthy. Just go there. Note that also the most important thing that I can say is please do not change any aspect of your medical care before you consult your physician, no matter what we say. Only your physician truly and best know how to take care of your medical problems. I want to thank OBHealthy for allowing us to use their platform to bring the webinar to you. Understand that, let me also say that OBHealthy is introducing a free, and did I say free? It is free, app And also, there's a code that you would put in for OBHealthy's app. It's 365. Put in the 365 code when the code comes up, and you will receive the app for no charge. The app consists of healthy eating, weight loss, and health and wellness ideas. This is so important, especially in the time of COVID, in the time that we're all stuck at home for the last year and a half, and we're all gaining weight. We need to make sure that we pay attention to hypertension, diabetes, heart disease, and this is one of the ways that can be helped. Understand that, and I truly understand that you're taking, each of us care about let me say this, each of us care about our health. You're taking a Saturday afternoon to listen to physicians talk about health. That means truly you care about your health. So let's improve our health, because our health is so important. So download the app. It's a free app. Just make sure you put in the 365 so that you get it for free. All right, download the app to your phone today. All right, let's continue. We have so many great questions, and there's another question that came up. It states that, does the diagnosis of diverticulitis, I should say, it said diverticulitis, mean that a bowel perforation is likely, or can it be effectively managed with diet and medication? How long should a person remain on an acid reducer like omeprazole? Okay. Dr. Prosper, can you start us off on this? And then I'm sure some of the other doctors will join in.
Let me go first regarding the diverticulosis. Tubercular disease is a very common entity, particularly about 60% of person over age 50 will have some type of air pocket, what we call a diverticular disease. Most of the time, 70% of the time, they tend to occur in the left side of the colon, particularly in the Western country. But for Asian population, for some reason, they tend to be more on the right side. So diverticular disease is very common, but you could have, there's a difference between diverticulosis and diverticulitis. If you have diverticulosis, you don't have diverticulitis. Diverticulitis entails some inflammation and occur very rarely. And the vast majority of the time, the diverticulitis, the episode of abdominal pain, some discomfort, and sometimes you could have fever or not, they're uncomplicated. So when you have a diverticulitis, you don't automatically have a complicated diverticulitis with perforation. There is some patient, particular bed-bound patient who got bad diabetes or got chronic constipation for some reason. They might have an episode of diverticulitis with microperforation. But most of the time, we don't have to do. When it's a microperforation, you don't have to intervene. You just manage those patients conservatively, give maybe some bowel rest, some antibiotic, and wait and follow, imagine study to see whether they progress.
Interesting.
Can you tell us how diverticulosis or diverticular disease develops in the first place?
Excuse me, I didn't hear the question.
Could you talk about how the diverticulosis or diverticular disease develops in the first place?
Most of the time, they don't know exactly the pathophysiology when it comes to diverticular disease. They're talking about sometimes you have some dysmotility, and they think at one point people have chronic constipation. But most of the time, there's no clear, you cannot say pathophysiologically, this is the way diverticular disease. But we have to assume the old age for some reason is the most common. And it might be related to some type of motility disorder. But a lot of patients, they think that chronic constipation or some type of medication, that's not true, that's not been proven. It's very, very difficult to say exactly. But we probably say more some type of motility disorder is sometimes most of the time in the old age is the reason. I don't know, maybe the colon is getting older, it's probably not the same thing. Although we see some patients as young in the 20s, 30s, and 40s who could have diverticular disease. And again, when they have some complication, they tend to be more significant. But the incidence and pathophysiology of diverticular disease is not well established.
Yeah, let's just talk also, just explain to the public what we're talking about in the bowel when you're talking about, or the colon when you're talking about diverticular. You're talking about an outpouching, but is that outpouching thinner, or is that outpouching still has the muscular layer of the bowel so we don't have to worry about perforation? I think that's what the initial question was. And diverticulitis means inflammation and swelling. Diverticulosis means no swelling whatsoever. And also, what can people eat? Are there certain things that may get trapped in that outpouching, like nuts and stuff like that, that may cause the infection or the swelling to be worse as we go on and live with this disease?
Okay, that's a good question. Many years ago, we used to say to those patients, whenever you have diverticular disease, you got those air pockets, avoid seed, avoid grains. But we found that later, more and more, there is no evidence that eating seed or something, we no longer, as a gastroenterologist, tell the patient not to eat seeds, because there is no evidence that the seed is going to go and stuck there, create from somebody from diverticulosis to diverticulitis. And we know there's so many conditions, so many food, we got seed, we got grain. If you tell the patient, we use in the beginning to say, avoid seed, avoid that, avoid grain, because the microbiome, for many years, there's no evidence that patient eating seeds or make it worse. As a matter of fact, they become a quality of life issue. Patient got diverticular disease, and we tell them don't eat seed, and at one point they have to they don't want to eat beans and rice because they think it's going to get stuck there. There is no evidence that make it worse. We no longer, as a gastroenterologist, will tell the patient, oh, because you have diverticular disease, you shouldn't be eating seed. It's always good to get high fiber diet. That's okay. Again, it's not a level A, B evidence. That's it. But sometimes we don't have anything to offer. We say eat your high fiber diet, avoid seed. But definitely don't tell the patient avoid seed, because there is no evidence that make it worse. It become a quality issue, because they go outside, they don't want to eat beans, they don't want to eat orange, they don't want to get stuck. There's a lot of patients. It's so common, because you got 60% of people over age 50 got diabetes. They never got a colonoscopy. You never got imaging study. They're eating everything. And suddenly they show up, you got a colonoscopy, you tell them that you got diverticulitis. The next day, it become an issue for them. They got diverticulitis for the 15 years. They've been eating everything up to yesterday, and you go out tomorrow, we tell them don't eat that. This concept is no longer at least quite strong at this point.
Okay, thank you. Yeah, there's another question that came in, and I think it's interesting. Let's answer this question. Let me read it. I have a COVID-related question. There seems to be a lot of ambiguity, surrounding the Delta variant, which is understandable. We're still studying it. But with that said, it seems much of the country is continuing to move forward with lessening the mask wearing and social distancing. While I know many studies, early studies, I should say, and many doctors are suggesting that vaccinated folks are fairly well protected. Even experts on the TV are saying that they wear masks inside. This leaves me confused. Could you help clarify? So, and I understand that there's a lot of confusion out there as far as COVID is concerned, and it truly has not gone away. Can we open the stage and start talking about the variant and those people vaccinated, those people not vaccinated, and the risk that they're taking? Dr. Sprock, can you help us out a little bit?
Yeah, what I would say is that when we talk about the coronavirus, COVID, most of the vaccines that are in use in the States, the 3 vaccines that are in use today are highly protective against severe illness and preventing people from dying. these vaccines were never intended to prevent people from getting actually infected from the virus itself. But all the deaths that were associated with it really were initially respiratory deaths. There've been some cardiac complications, but by and large, it's been spread via the respiratory tract. And I think that as more and more people have been vaccinated, that the people that have been reluctant to get vaccinated are now almost universally the only people that are dying from COVID. And so what we've seen is that most of the individuals that have been vaccinated have been protected from getting very, very ill, getting admitted to hospitals, getting on respirators, and dying. And so those individuals that have not gotten vaccinated are those that are now dying. And what happens is that as these viruses tend to survive longer into the community, they change. Someone mentioned about genetic changes. There are genetic changes that have occurred. And the longer that they live, they're bound to be these kinds of changes. I'm not so sure that anyone truly believes or understands scientifically that these variants are worse than the original. And part of the reason for that is that given the number of individuals that have been vaccinated, the number of individuals that are likely to become infected is a lot less now, and therefore to get admitted to the hospital and to have these severe complications is less. There's some talks about, from Pfizer saying that there may need to be a booster. I think that might be Pfizer's interested in boosting their revenue as opposed to any scientific evidence that says that you actually need to get a booster, because I think that for individuals who've been fully vaccinated, that means they've gotten the 2 shots of either the Pfizer or the Moderna or the one from J&J, they've gotten pretty significant antibody, not just antibody, but some cellular immunity against the coronavirus. And if they happen to get exposed again to either the original corona or any of the variants, they're likely to have a pretty good immune response that would prevent them from getting sick or hospitalized. And the other aspect is that a large number of the individuals in the United States who haven't been vaccinated are children. And so they now have, for the Pfizer, children that are over 13, and then Moderna is looking at studies for children under that. But you need to understand that of all the mortalities that have happened to people that have contracted COVID, less than 0.2% have been children. And we don't know why that is, but children have not been significantly ill or damaged from this COVID. And whether or not, it's likely to happen that they'll now start to get ill or significantly affected by variants, we just don't know. But my belief has always been that given the low mortality and even morbidity in children, that it's really the adults, especially the older adults, that are still going to be at the highest risk. And I don't want to be crass, but I think by this point, anyone that wants to get the vaccine, unless they're not eligible to receive the vaccine, should have gotten it. And if you haven't and you get sick, as far as I'm concerned, shame on you, because you've had the opportunity, you could have gotten protected and you didn't. And what we're now seeing is that's now who is dying. So I think that at this point, I would say to those folks that have been hesitant that again, they should get it if they haven't, especially as we're now starting to get to the fall again, where respiratory viral infections start to increase in frequency. Remember that we thought that we were going to have a lot of problems with influenza last year. But guess what? Because of all the protection that took place in terms of the masking, the social distancing, and everything else, the number of influenza mortalities was very low. And in children, it was almost non-existent. It was scary. I think that what we're going to now see as things start to loosen up in terms of people, not wearing masks, social distancing, the likelihood is that influenza is going to be a lot more prevalent than it was last season, even in children. And in children, especially with influenza, the very young children and the very elderly were the most severely infected. Not so with COVID in terms of children, but yes, with the elderly. And so I would suggest that the elderly Once the influenza vaccine starts to come around in the fall, they take that. I don't think that there's going to be any significant recommendation from the CDC about additional boosters relative to COVID, even with the variants that are coming out.
Here, let me, if I can chime in a little bit.
Yeah, please.
So there is some evidence that the Delta variant is different to a certain extent, but there's still a lot of protection from the vaccine. And if I understand, the Erica's question, the question is, well, if people are vaccinated, if experts are vaccinated, but they're saying because this Delta variant, they still wear masks inside, why are they taking these precautions? And I'll tell you, as an individual who's vaccinated but still walks around with the mask, is that I am more concerned for my fellow citizens. Dr. Sprock said something. The vaccine will not prevent you from getting the infection. The hope is that it prevents you from getting sick from the infection. But if you do have the infection, there's a question as to whether you could pass that infection to someone else. So just because I am protected with the vaccine as a physician, as an individual who's dedicated my life to helping other people, I want to make sure that if I am in an environment where somebody else could get the virus from me, that I protect them. And that's the reason why I still wear the mask. There's another communal reason to do so. Organisms that are as contagious as COVID have the ability to randomly suffer alterations in their DNA. And these random alterations can lead to genetic advantages that make them behave differently under the stress of vaccines in a population. And as long as we as a population of people give the virus an opportunity, in a planet, give the virus an opportunity to, it's going to get a little bit technical, but use natural selection to sort out which of these advantages can flourish in an environment, it will. The Delta variant, the lambdoid variant in Central America, it's happening in other parts of the country. And it is possible for the virus to mutate in a way to make the vaccines ineffective. And we find ourselves back in a situation where we were a year ago, where we really don't have anything to fight this but social distancing, right? The probability of that, I don't know. I don't think anyone knows for certain, but we have certainly seen variances that are different enough to make them behave differently in the public and in a community. And that, the smart thing for us to do as a culture is to get vaccinated, and if not, still behave in a way to where we protect one another and not allow the virus to spread and mutate and potentially behave differently.
Right. So what you're talking about is, if you're not vaccinated, then you could be a Delta variant carrier and spreading Delta variant throughout. So
vaccinated, you can be a Delta variant carrier.
Right. Anyone could be,
from it.
but it's more likely someone who is non-vaccinated. And so,
Omar, I just need to make I'm particular about words.
Okay, all right. Maybe,
so when you talk about being a carrier, most
right.
folks that are talking about being a carrier means that you are carrying a bacteria usually,
right,
and no longer symptomatic.
Right.
Most viral illnesses, you get exposed. There's a certain amount of time where you're not symptomatic. You become symptomatic, and then you eliminate the virus. Right. There are a small number of individuals who are persistent sort of carriers of the virus longer than the 14 days. But in general, most folks that have viral infections, they have that period occur, and by after 14 days or so, that virus is gone. They're not able to infect anyone. As a matter of fact, most of the people, even though they still might test positive for the virus,
right,
after about 10 days, they usually are not contagious and can affect other folks. I think that the issue is that since these vaccines were not designed to prevent people from getting infected, people can get infected, and once they are infected, they can spread it to others. Right. There is a question, however, about how infectious you are, a question, if you have had the vaccine and you get infected. We believe that you can infect other folks, but the ability to get infected is related to a number of factors. And one is how much of a viral load you're actually exposed to.
There you are.
And so if you're
Correct.
exposed to a large viral load, especially in a closed space, by someone that's coughing and coughing up the virus, then there's a good likelihood that you may be exposed.
Mhm.
If their patients are not so symptomatic, the question is whether or not, and they're not coughing, how much they're exposing other people to it. Remember that when they talked about the social distancing of however many arbitrary feet it was based upon the ability to cough and expel it. Well, if these individuals are not symptomatic, and especially again, if they've been vaccinated, they're not so symptomatic, there's a question as to whether or not they are as able to spread the infection as someone who's asymptomatic. So there are a lot of variants. Remember, this virus has only been around for a year. And there've been, I don't know how many, maybe 12 or so variants that have been occurred, and they still are there. And I think that you know, Lawrence is entirely correct about being very conservative, I'll say, in terms of continuing to wear the mask to prevent infection of other individuals. And I think that's appropriate. But I do believe that you know, as things go on, we will know what's going to happen as time goes. The ability to predict what's going to happen with additional variants, I think, is you know, unknown at this point. I do think that as you know, again, that you look at what goes on in the South, very often in the Southern Hemisphere, their seasons are very different than the seasons here in terms of the ability to spread the disease. But I think that as we look towards the fall, I think we're looking at the increased spread contagious of all kind of respiratory viruses, and COVID will be one with flu and respiratory syncytial virus and rhinovirus, common cold. All of that stuff's going to start to come into play.
I think what's happening, you know, we amongst us as physicians and people who've taken pathophysiology, biology and microbiology, we can get into the minutia of this. But what Erica was saying was it's confusing, right?
Yes.
It is confusing to have people talk. It's confusing to get into the details specifically about what risks exist, what risks don't exist. How do you stratify this for these risks? So from a public policy perspective, I think it's pretty simple. And that is, you know, we have done, the vaccine has helped us in many ways, mainly on the backs of the people who were considerate enough to get the vaccine, considerate enough for themselves and for their neighbors. But now that we have a significant portion of the population, at least in our country, in more states than others, who are unwilling to do so, then we have pockets of population where the vaccine might be able to flourish. And in doing so, might be able to mutate.
The virus may be able to.
The virus, I'm sorry, the virus. So then the question becomes, how do we as individuals behave in that climate? And me as an individual, even though I'm vaccinated and I feel very well protected, right? Even around someone that might be COVID positive, right? My tendency is to continue to wear a mask in those places without ventilation, right? In those places where you might be in close contact with someone, where you might sneeze or receive a sneeze or vice versa and put someone at risk, considering whether you may not necessarily know whether you've contracted the virus or not. So to answer Erica's question, it is confusing, specifically for what Dr. Sprock was illustrating was that there's a lot that we don't know, and it almost takes, you know, academic and intellectual jujitsu to really get a handle on how you're going to approach it. But for the public, I think it's pretty straightforward. It has to do with how, you know, whether you want to look out for your neighbor or not, whether you want to exercise precaution and be conservative in terms of your approach in the public. Me, for one, although I'm protected, I continue to wear masks because I'm really interested in protecting other people.
Yeah, and I think that
I didn't mention, and it is important, is that, you know, not everyone that gets the vaccine is going to respond to the vaccine, especially people that have immunocompromise.
Yeah.
Might be on steroids, or they might, be on medicine for cancer. And so, and one of the deaths that occurred, I mentioned it before, the previous was from someone that was fully vaccinated but had a lymphoma. And he went to the emergency room, got sent home, and then came back to the emergency room. He had COVID, and he ended up dying. And when they looked for the level of antibodies that he had after he'd been vaccinated, it's very low. And so when you're out there in the public, you don't know how many individuals who might have been vaccinated or who might be immunocompromised that if get exposed, they could die. And again, as Dr. Lawrence mentioned, if you have it and you pass it on, you wouldn't want to be responsible for that. I think the issue is as CDC mandates. If I was just on a plane, everyone on a plane and in the airport and on a train has to be masked. The same thing if you're in a taxi. But also, I still will not go and eat inside a restaurant unless it's because I see folks all the time. I still want, if I go to a restaurant, want to eat outside because I think that you're at less risk because you're in open air space. But I think that it is important that and I think it does break down to whether or not you're I'll say sympathetic enough to be interested in protecting folks other than just yourself. There are a lot of folks out there who don't care anything about anyone, and I think certainly sometimes not even about themselves in terms of how they are. And at this point, you now know that since things are relaxed, who those folks are and who the folks that are fully vaccinated. That's the reality.
I was talking to an infectious disease specialist in the hospital making rounds this morning. And at this particular point, she states the patients that are coming into the hospital that are having significant problems from COVID are patients who are unvaccinated, who are not vaccinated. She is not seeing patients coming into the hospital who has had the vaccine those patients are not having difficult problems. Even if they can't catch COVID, she's not seeing them in the hospital. They're able to get through the virus without hospitalization. So that's something to be said from a person, her specialty is infectious disease, and this is what she's seeing. It's so important that I feel was right what Dr. Sprock is talking about, that we should seriously think about getting the vaccine if you haven't gotten it already.
Not to overboard it, to give numbers to it, because numbers or statistics are really very important. Recently, in stated, and even the gentleman, what's his name again now? That 99.2% of those who die now die from those who were not vaccinated. And that's numbers, and that's a fact. And that's something we need to take into cognizance. But what I always tell a lot of my patients and friends and those who still haven't vaccinated, and I say, look, if you gave an option to those who died from COVID-19, if they could take the vaccine, what do you think they would have done? They would take it. I mentioned names of those we know who died before the vaccine came out. If they had just waited a week, 2 days, 3 days before, and the vaccine came out, they would still be alive today. Just like when HIV came out. I mean, people were dying from HIV until that particular day when the drug was approved that it treats HIV. And from then, people are living. So the question is, for those who are dead, it'd be a huge dishonor to them for you to be alive and not take the vaccine, and then be a harbinger for the virus and given the risk for the virus to mutate. I mean, we're talking about Delta virus and all that. We're giving names. Now, when the virus first came out, it first appeared in India, I must say, they initially thought it was 2 mutations, and then it became triple. We found out it was triple mutations. But in order not to castigate or cause aspersions on a certain group or ethnic groups, they decided to give it numbers or codes. And now it's called the Delta variant. So we know that those who begin to harbor this virus are those who are unimmunized or not immunized, or those who are severely ill. A typical example was the case of the UK variant, was actually picked up from a gentleman with lymphoma who had the virus for 9 months and eventually died from it. So, in our community, especially the Black and brown community, please take your vaccine.
Yes, yes.
Nelson, I just want to say this, I dare say all of you have encountered some folks. It doesn't matter what you tell them. Doesn't matter who dies. I mean, some folks say that, some folks call it woke. These people are woke. That means that they have, and so they believe that these.
The 20% of them.
But Nelson, you tell them that 99.2% of the people that are dying today are unvaccinated, are going to say, I don't believe that. And I'm not going to get it because, and you have to, sometimes you just have to say, you give up, you do the best you can, but some folks, I don't care what you tell them, there's some folks that believe in Dr. Atlas and what he believes in, and Dr. Fauci's the devil. So, and sometimes people are not interested in the truth. They're interested in what they believe. And if they believe that this is, going to change your genes and do this and this and this, they don't want to hear it. So there's a group of folks that are out there that I don't know what you can tell them. They're not going to listen.
Yeah, unfortunately, that is true, Dr. Sprout. Unfortunately, I'm just trusting as time goes on, we can convince more and more of them to get the vaccine. And that's all we can say. We never give up. We never stop preaching, as I say. Never stop preaching, brother. All righty. There's a question. Let's get to another question. When I stand up, it is not uncommon for me to get temporarily lightheaded. What could be the cause? And should I be concerned? If it helps to know, I am middle-aged, overweight female. Dr. Atherley, can you help start us off with this at least?
Yes. If she clearly responds or describes an episode of lightheadedness or recurrent episodes of lightheadedness with changing position from sitting to standing, then we think of what may be occurring in the body when you move from a sitting position to standing position. The thing that comes to mind most readily is a change in the blood pressure. There may be accompanying changes of pulse rate, etc., regularity of the heartbeats, lots of other things may occur, but the common thing we think of is so-called postural hypotension. That is, whereas you change your posture to assume a standing position, that the blood pressure falls. One simple way of looking at it is to assume that the blood falls, or it goes primarily to the most dependent areas, the lowest areas of the body, and there's not enough circulating to go to the brain and other vital areas. So that needs to be documented if that is so. And the very simple first test after proper discussion and evaluation of the patient and examination, the first simple test will be to check the actual blood pressure in various positions. Have the patient laying, sitting, and standing, and see if indeed there's a significant enough drop. In all of us, there may be a small drop, but if there's a significant enough drop in the upper number of the blood pressure, then it may define postural hypotension. There are simple measures one may consider before going to medications. Proper hydration, et cetera, fluid, stop certain medications which may cause it. And if we need to go to medications, there are some medications which can be used to help restore appropriate blood pressure if it is falling inappropriately. That's a quick thumbshell of it, because there are many other more sophisticated tests that can be performed to see if we have the so-called postural hypotension or falling pressure with changing posture to supine, from a supine or laying to a standing position.
Right. What about as far as the arteries in the neck being narrowed? Would that be something that you should evaluate to see if the blood flow is changed because the arteries are too narrowed, other than from cholesterol or whatever, then the blood flow is decreased to the brain, that you're getting a little hypotensive or a little, feeling as though you're going to faint?
think Lawrence may want to address that to some extent in terms of the brain and the brain function. But I think that ultimately a proper and total evaluation would include that. It would include the monitoring for irregular heartbeats. It would include the monitoring from blood flow through the carotid arteries or the arteries that go up to the brain. It would include a lot of other aspects, but the quick, simple answer would be to first of all look to see whether the blood pressure falls. Well, Lawrence, do you want to address any neurological aspects?
Oh, you're on mute, Doc.
Sorry, the neurological aspects of what again?
When the patient stands up, they feel as though they're faint.
Yeah, so whenever you're not getting blood supply to the brain essentially turns off, right? And so you can either pass out completely or you can begin feeling lightheadedness. And so like Dr. Atley was referring to, sometimes, you can have conditions with your heart, you can have conditions with something called systemic vascular resistance, which is how quickly and rapidly your blood vessels vasoconstrict, get smaller to accommodate for changes and blood flow to certain parts of the body to accommodate for gravity. So if you stand up, gravity is going to pull more of your blood to your brain. Your nervous system, your brain, your nervous system, your autonomic and parasympathetic nervous system, the parts of your nervous system that regulate reflexes, so to speak, they automatically kick in gear and they vasoconstrict your blood vessels to redistribute blood. But if you have an abnormality in that system, or if you just have low blood pressure, hypovolemia, low volume in your blood pressure, then you can get that lightheadedness and you'll feel it. Your brain doesn't get enough blood supply and you'll feel it with that dizziness in your brain. But oftentimes what you need to do is you need to correct the underlying cause of it.
My approach is simple. It's the brain requires two things: oxygen as well as glucose. Glucose specifically, but more often than not, the issue is as Dr. Atley said, related to oxygen. And one of the things that you need to make sure of is that even though it may be related to posture, there could be an underlying issue of anemia that might also be responsible. Most of the oxygen that's carried through the blood is carried via the red cells, and it's not dissolved in the blood. It gets released. And so you want to make sure that she's overweight, that she's not hypotensive, not having hypoglycemia or issues related to diabetes, but also whether or not she doesn't have an underlying anemia that might have this postural aspect aggravating the situation.
Excellent. Go ahead, Dr. Aluya.
No, I know we have a few minutes left, but I thought since this is a GI topic, we should talk, a few minutes talk about one of the prevailing cancers that's pervading our community, and that's colorectal cancer. If we could talk a little bit about that, we have the GI specialist to talk about it, and let us just contribute to this so that we can get our community informed.
Okay, excellent. Dr. Prosper, yeah. We're talking about colorectal cancer. And there was one question that came up: when should they do an endoscopy? But I think the most important thing is a colonoscopy. Let's go. Can you help us out with that?
But exactly, we have a major, particularly in the Black community, and it seems the information is not getting to the community, and we, as a physician, should talk to the primary, everybody involved, and talk to the family. Colon cancer is the most known cause of GI tract when it comes to America, and pancreatic cancer is number 2. But the point of colon cancer, that's something could be particularly prevented. But we, just by doing a simple test. But there's a menu when it comes to screening for colon cancer, for whether you got a barium enema, whether you got a Cologuard, you got a blood test, you got stool testing. But the one that's probably more effective, probably one shot, always a bit expensive, is to have a screening colonoscopy. Usually, because colon cancer tend to be a disease in old age. Up to 2 years ago, they used to say you start screening at age 50. But finally, the American Cancer Society, they agree, particularly in people like us, that everybody should have a screening colonoscopy started at age 45, just as in a regular population. Now, if you have a family history, you have somebody, you got a first degree relative, or you have a second degree relative, or a second degree relative, or you have somebody in your family who would be below 50, you should start screening even early. As a matter of fact, there's a condition where there's a very rare condition, very cancer, different type of cancer in the family and the first degree, where they got thyroid cancer, you got breast cancer, you got or pelvic cancer. Those things, when you put you in a special category, what we call Lynch syndrome. So if there, for some reason, you have a brother or your parents, you got colon cancer, ovarian cancer in a female patient, thyroid cancer, skin cancer before age 50, there's some type of minimal investigation you should do to make sure it's not genetically related. Because colon cancer, most of the time, above 89% of the time, they tend sporadic. But 8% who have a genetic, this is the one we target. If you have a brother, for example, you have a colon cancer before age 45, and they find out for some reason the type of cancer is not sporadic, is more genetically linked, is your obligation as a physician, as a person involved, to make sure you give the right information to the first degree relative, particularly younger, when they're not taking. We're talking about disease of the old age, but if somebody is 45, he has a microsatellite instability, we start screening even the kids starting age 22. This type of question you have to get. And particularly in America, we used to say that up to a few years ago, African-American people should be started screening at age 45 because the disease tend to be more aggressive than us. And there's to demonstrate for some reason, black population probably the colon to tend to age a bit longer. There's somebody look at it, they find out our colon tend to age a bit quicker than the other folks. For some reason, we tend to have the disease maybe early age and tend to be more aggressive. So colon cancer should be, you should start doing something because it could be prevented. The rationale to do the colonoscopy, they look for some type of what they call polyp. Not every polyp is different. For every 20 polyps, maybe one will become cancerous. But whenever we do colonoscopy, we see a polyp, we remove it, and we probably make a big difference. Mm-hmm. And the good thing about it, if you have a colonoscopy, you got a colonoscopy, stop it. You have no family history, you're good for 10 years. There is no reason somebody should die from colon cancer at this point, providing they do some type of screening. I'm not saying if you don't want colonoscopy for something, you could have a stool study, basically, but you would have the advantage to remove the precursor of cancer. That's what we're looking for. The colonoscopy gives you the opportunity to remove the polyp. There's a last name attached to that polyp. We call adenomatous polyp because this is the one who got the potential. Not every adenomatous polyp become cancerous, but if you're gonna develop, it's gonna start with some type of adenomatous ovulous polyp. But please, what we should tell the population, get tested early for sporadic, even whether you're male or female patient at age 50. And if your family history at age, you got some type of rare malignancy, even you're in 20s, 30s, you should be looking, at least try to get some type of advice whether you should get tested early. It's not only for colon cancer, but pelvic malignancy or something. If you have a brother or your parents and you got the 2 or 3 second degree relatives, you got some type of malignancy or different type, that will tell you to put in position to go. Don't have some type of screening. Some screening is better than nothing, but the preferred one would be a colonoscopy, particularly when you're a gastroenterologist. That's what everybody wants to the population to know about.
So, Dr. President, I'm going to sort of ask a specific question that talks about the percentage of gastroenterologists that are of color. And you know, there's been part of the introduction that Dr. Bay made is we're trying to get Black men to go into medicine. And increasingly the number of Black men versus Black women are overshadowing the number that are going there. And then as you look at certain kind of specialties, it gets even bleaker. And the demographics of the country is changing, that, you know, the majority of kids being born in gay are Latino and African-American, but the pipeline of Black physicians, especially certain specialties, and I could ask you, Trevor, about Black cardiologists as well, but what's the trend been as you see it in terms of African-Americans in gastroenterology, the numbers?
The numbers, unfortunately, is not so big. Up to like 15 years ago, we got a big society called Leonard Society. We used to meet every year when we got digestive disease week. For the last 10 years, we have no meeting at all. And the number is growing less and less and less. But fortunately, there's up there, like 2 months ago, there's a group, young GI at NYU. They just tried to put together, and they're young, much younger than us, they tried to put a Black Gastroenterology Association. And I hope that's gonna go and spread over the country. But we had it many years ago. And if you go now to the national meeting, I see less GI doc involved in the field. And so those who are involved, they're dying, they're retiring. So it's for us to go and talk and get, and particularly at the level of medical student, to do that. But the numbers, it's much less.
Because I think that there's no question in my mind that you know, when you talk about certain kinds of things, especially preventive things, that there's probably a disparity between the number of folks that get screening colonoscopies if you're Black or if you're white, and if your physician is Black or they're white. And the same thing could be talked about in terms of in cardiology, whether or not you're going to have ultrasounds or you're going to have stress things. And some of it has to do with, you know, our willingness to see physicians, but also related to physicians that are like us and have an interest in our outcomes. And so I think it becomes important, especially as you look at that declining number of Black men in the medical schools, that then decreases the number that go into various kinds of specialties and then subspecialties. And so, you know, it was a leading question because I think I already knew the answer to it. But, you know, despite COVID, I think the numbers are declining over time, and you know, and the numbers were probably greater in our generation than they are in the younger generation. And so, you know, we really need to dramatically encourage folks to go into the health professions, especially in the medical school. And I saw that Dr. Aluya was kind of frowning when you said it hadn't been a meeting in 10 years.
Well, again, to give numbers to those, there've been 20% drop in the number of young Black men going to medical school, period. The numbers do. And we have stood up to see what we can do. And as we have individuals of our color who are not in the field taking care of us, then our outcomes would eventually turn out bad. I mean, statistics have shown, once again, that you are more likely to do well or live longer or survive if you're taken care of by somebody who looks like you. I mean, that study actually came right from the NICU as well, even from neonatology, those who were born newborn babies. So if you extrapolate all the way up to adulthood, it's the same all through. So I don't know what we can do other than what we're doing here, as well as individually taking charge of our individual spaces and going out there to speak to young people. I guess we must begin to raise a culture and identifying young Black men who will raise into medical school. Maybe that's the next step.
So Lawrence, how many Black neurosurgeons you think there are in the country?
Wow.
Well, how many in New Jersey? Just do New Jersey. You probably know every neurosurgeon.
Right? Can you count them on one hand, Lawrence?
I mean, in New Jersey that I know, Man, you know what? I've never, in New Jersey, I've never thought of it. It's depressing. I'm not even going to say the number. This is what I'll say, because I can only think of two. I can only think of two in New Jersey. It can't be. It can't be the case.
Yeah, and you're including yourself.
Yeah. So this is what I'll say. There's about 5,000 neurosurgeons in the United States. I was invited into a group, a WhatsApp group, and everyone tried as hard as they can to get as many Black neurosurgeons invited. And I think we got up to like close to 200. And we were like, wow, like that's amazing.
Out of 5,000.
Out of 5,000, yeah. And that's including residents and fellows who are in training. About half of them are residents and fellows in training. So, and I'll say something else that's, this is kind of depressing at the end of the conversation, but I think it needs to be a conversation that needs to be had. And thank you for bringing it up, Dr. Spock. But even beyond what we do to take care of patients, what about the new therapies that are coming down the pipeline, and which diseases are being funded and which resources are being pointed towards the problems in medicine that are being addressed? And if we don't have physicians at the table to speak to these problems specifically, we are unlikely to get the resources put into the places to take care of not only what we suffer from now, but the diseases of the future.
Right.
I think, to that point, you look at the number of, minorities that finish medical school, that then go into academic medicine. It's horrendous. And if you look at the top of the pyramids of that in terms of, faculty members, full professors, chairman of departments, things like that, it's not a pretty picture. And it certainly doesn't reflect the demographics of what's happening in the country. And when you talk about some of these cutting edge therapies in terms of, like cancer, where they're developing, not chemotherapies, the chemotherapies have gone and increased in numbers, but now they're sort of looking at the outcomes related to genetics of the population. Look, I had a lecture from MD Anderson where they're saying they can take some white cells from a person, ship them out to California, and sort of weaponize them against a particular form of cancer, send them back, infuse it to it, and it wipes out specifically those cancer cells. So how many Blacks are involved in that research, and how many Blacks are involved in those kind of clinical trials?
Here, wait a minute. So there's a gentleman named Dr. Keith Black at Cedars-Sinai. He's the chairman of neurosurgery. He has a research lab. He has about 15 NIH grants. One of the people who he worked with in that lab is a gentleman named Dr. John Yu, who's working on a dendritic cell vaccine. I know because I used to work with him with it. So we do have a brother actually working on that right now.
No, I'm just talking about in general. I mean, but my guess is, where is he?
He's in Beverly Hills. He's at Cedars. He's the chairman of Cedars-Sinai Neurosurgery.
Yeah, but my point is that, and again, I'm not to be beat it in a dead horse.
Get your point.
Start to look at certain kind of specialties, and some of the most competitive specialties are surgery, orthopedic surgery, neurosurgery, ENT, and you look at, well, how many ophthalmology? How many Blacks are going into those particular specialties when, number one, there's a certain revenue associated with those specialties, and then number two, the competition is going to be very, very great. It still is a disparity in many of the surgical specialties, men versus women. But when you talk about African Americans in some of those, you're an extreme rarity.
Yeah.
And again, it's going to be decreasing, especially when you look at, I don't think that the gender issue is going to go away that quickly. And so if you look at the declining number of Black men that are going into medicine, then the number that might be able to get into these kind of specialties is going to be tougher.
And also, I noticed, well, Dr. Lilia, I noticed, I'm not going to forget you. We're going to extend this conversation because I think it's so important. But understand that if you're not at the table as a Black physician, be it female or male, what about research on certain diseases like sarcoid? And I have a huge sarcoid population of patients, and it's so prevalent in the African-American and Hispanic communities. But what type of research over the years has come through for sarcoid? And if we're not at the table, if we're not governing, if we're not at the table that we can direct dollars towards different research, it's not going to happen. Dr. Aluya.
Yeah, so Dr. Daniel brought up a very important question, and that's the question of medicine and the future of medicine as regards to technology. And I'll use your word, what you just said, and I give speeches about this all the time. If you're not at the table, you will be on the menu, period. And that's why, and I often call myself a medical advocate. There's a reason why I do that. Now, I've given lectures on, the future of medicine and what it looks like for us in the future. I did give out, and I think the last time or two minutes ago, I talked about 5 technologies that's going to affect how we relate with one another and how we relate with our environment. The first one is artificial intelligence, and I'll come to that. Second one is the 5G technology, or the communication technology that's going to come up. The third one is blockchain technology and in medicine, how it affects it. The fourth one is the cryptocurrency that's involved in management of reimbursements and everything else that's going to come up. And the fifth one, of course, is the mRNA technology that we'll use now to handle COVID and eventually every other disease that's going to come up down the pipeline. We've heard about CRISPR. CRISPR, how many of us know what CRISPR is and what the technicalities of CRISPR is? And what does that look like for the future of medicine? Now, AI is being applied on a daily basis to medicine, especially ophthalmology. I mean, they have a huge flow of the mapping of the iris, the mapping of the retina, and all those technical issues that artificial intelligence.
Radiology and pathology as well.
Right, but it's so much faster in ophthalmology, and it's coming up. And how would that affect neurosurgery in the future? How would that affect, how we manage common diseases and the research that comes with those diseases? You just brought about sarcoidosis. As a matter of fact, I grew up in Nigeria, read in Nigeria, did all the things I did in Nigeria. We never saw sarcoidosis. And I've asked, it's still not there. It's usually not a black man's disease, but we know the origin of sarcoidosis with the Scandinavians and everything else. And anthropologically, how that has begun to be an issue with us as black folks here who have migrated here in the United States. I'll tell you this. Look, we all know that life began in Africa. Now, those who left Africa and who reside here left 30 to 35,000 years ago. We left only 500 years ago, willingly or unwillingly. But so we're just adjusting to the environment. And that's why diabetes wasn't a big issue in Africa. Africa was defined as a continent without diabetes. Now, for those of us who are here, it's an issue because we're taking time to adjust to the food, to the climate, to the genetic manipulations of the environment, or how it affects us. And that's why we have more of us who are dying from heart disease, more of us who are dying from coronary disease, with more of us who are dying, ending up on dialysis and everything else. Now, I'll give you a typical example. We talked about, the issue of why is the black man here in this country faring worse than any other race when it comes to heart disease. Well, we begin to realize, guess what? The black man does not have enough nitric oxide in his lungs, because when we're Africa, we didn't need it, but we were transported here. Now it became an issue for us to survive. So genetics, epigenetics, science and technology, anthropology, who is putting all of this together for us so that we can point a finger in the future to tell our folks and black folks, this is what's coming, be aware, be informed, be engaged.
True. Very well stated.
I'm not sure why I played a role in helping train this man.
I can see how you rubbed off on him, Dr. Sprout. All righty. Well, this
get his first job.
I'm going to tell you, it's just been a pleasure this webinar because the amount of knowledge and amount of topics that we covered today is just enormous. So I'm just so pleased in what we've done today. Listen, I'm going to say this because I don't want anyone to sign on next month inadvertently. Next month is the vacation month for the doctors. So we will not have an August webinar. No August webinar. We will see you in September. And just to give you a little tease, September will be just a little bit unusual. And I think everyone's going to love it. So make sure you tune in September, number one. Number two is, remember, every second Saturday at 1 o'clock, we are here trying to answer so many medical questions. And I must apologize that we didn't get to the questions, all the questions. Dr. Atherley, they were on you. I didn't get to the questions, but there were a lot of cardiology questions. Please, if you did not have your question answered this time, please come back next time and type it in again. We want to answer your questions. Unfortunately, we only have 2 hours. Okay, remember, caring and sharing. All right, let everyone know out there that we're here every second Saturday. Okay, do not, I'm going to say it again, do not change any aspect of your medical care until you consult your physician. Only your doctor can truly be the one that can truly tell you how the medical treatment is going to affect you, what you should do, what you shouldn't do. Pay attention to your doctor, okay? No matter what we say. And I just want to say again, thank you to OBHealthy for allowing us to use their platform. Understand, their app, the OBHealthy app. Go to the App Store, download their app. The code is 365. And did I say it was free? It's free. So have everyone download that app. It's healthy eating, it's weight loss, it's health and wellness, health videos, all of it's on there. Just download, tell your mother, your father, your sisters, your brothers, your church members, tell everybody, download it. 365 is the code that will allow you to have it for free. Did I say 365 is the code that will allow you to have it for free? Goodbye, everybody. I'll see you later and enjoy the month off, docs. We will see you later. All right.